Welcome to the Dental Implant Practices podcast, where each episode will explore how to integrate dental implants into your practice and into bone, with your host, Dr. Philip Gordon.
Welcome back to another episode of the Dental Implant Practices podcast. I'm your host, Philip Gordon, and today it's a huge honor for me to have on Dr. James Sanderson. James, thanks for being on the show.
Philip, I really appreciate the opportunity.
You and I know each other from working at the Implant Pathway Clinic down in Tempe, Arizona, is where we've met, and get to see each other a lot down there. You know, teaching implantology at the with Justin Moody and friends.
Several times a year.
Yeah, several times a year, several times a month almost. So I know you've got a very decorated past history for your dental career, and so I'd love for you to dive into kind of where you're from, some of your highlights through undergraduate and dental school, and then kind of walk us through the highlights of your career. Obviously, it's
Sure.
been a great career, long career for you, and you're not through with it, but kind of walk us through a little bit of that so my audience can get to know you a little better.
Well, I appreciate you. So I'm from Birmingham, Alabama, and my dad was in the first class of School of Dentistry here in Birmingham at the University of Alabama School of Dentistry. And when I graduated from high school, I was planning on doing anything but dentistry. I had the opportunity to go to the University of Alabama and went there to become an athletic trainer, and that was what I was going to do for a living. Went there and was fortunate to be a part of the 1978 national championship team, and just had a wonderful opportunity there. But then while I was there, I had some things change, and I changed directions and started heading toward a path in dentistry. And so that was a significant change, especially when you're not planning on going to dental school for a couple of years, and suddenly you have to have different kind of grades than what you had. But was very fortunate to be able to get in dental school. Graduated from dental school in 1984 here in Alabama, and started practice. Went in some for a short period of time with my dad, and then his philosophy and his background was Bank Institute. And so within a couple of months of getting out of dental school, I was down in Miami at the Bank Institute and learned a lot about head and neck pain, occlusion, and how to make the bite go together and all that kind of stuff. And so my practice was a practice that was really centered around, comprehensive dentistry, aesthetics, and all that kind of stuff. And in 1984, root form implants came on the scene with Corvent implants. And being here in Alabama, the Alabama Implant Study Club was a significant part of what I was fortunate enough to be involved in, and listen to some of those guys that were on the absolute front end of implant dentistry in the world. Bill Tatum and a lot of those guys, and the opportunity to sit and listen and talk with them and learn from them. And it was just a wonderful opportunity. I'll never forget my first implant that I was going to place in private practice. I chose to place the implant on number 7. And so I was going to replace that tooth with an implant, and I thought I had me a nice thick ridge up there, and I laid the flap, and I had the ridge about as thick as a piece of paper. What do I do now? So I closed it back up and started over. But from there, was very fortunate over the years we did a lot of full mouth reconstruction kind of things, but that also meant that implants were a part of it. And so the team that we had put together here, we did the first teeth in an hour here in the state of Alabama. We did the first all-in-4 case here in the state of Alabama. And we just, implants was a huge part of what we did. Another thing that we were involved in, and my practice was a private practice and a fee-for-service practice. And so as insurance became more and more prevalent, I didn't want to participate in insurance. And so I pulled out of the Blue Cross plan here in Alabama, which is sort of the big player here in Alabama is Blue Cross. And so I said, okay, if I'm not going to be doing insurance, I've got to separate myself or differentiate myself in some way. And so we chose to do that with service and also with technology. And so I had, in 1992, I picked up digital radiography. It was digital photography as soon as it came on board. Doing stuff through the Pankey Institute. Photography was a huge part of what you did in your case presentations and all that kind of stuff. And so 35 millimeter photography was, you had to be a little more precise. Or really not the word, it's precise, but you just didn't know if you really got what you needed until you got it back from the developer. But once the digital SLR cameras came available, that really sort of that was wonderful from a case presentation perspective and all that kind of stuff. And we was fortunate enough to be able to use microscopes in the practice. We used microscopes for everything, to talk for a while about microscopes. And then my oldest daughter, after she finished ortho from the second grade until she was 13, we ended up with a unilateral gummy smile. And David Sarver is an orthodontist we use. He's one of he essentially wrote the book that most of the dental schools use in ortho. And so, I couldn't get a better orthodontist to do what we were trying to do. And David and I have been great relationship, great friendship. I learned a ton from David over the years. And when we got finished, I looked at him and I said, we got a unilateral gummy smile. He and I were involved in a lot of orthodontic cases. And, unilateral were really tough. And so I told him, I said, the only way I know to fix that is with a laser, but I don't know anybody that owns one or knows how to use one. And I needed to go buy me a laser. And so David called me the morning after I got my first diode laser, and he's like, James, I'm flying to Miami at noon, and I'm going to give a talk tonight, and I need your post-op pictures on Sarah with laser. And I was like, David, Sarah's in middle school, and Katrina's going to kill me if I get her out of middle school to come do this. And he said, I got to have the slides. So, I got my daughter in. I was told you can do this without numbing. So I didn't numb her up and recontoured the gum tissue. It really looked like a really nice result. Got him the photograph, emailed him the photograph. And that night, he went through her case, and he got a standing ovation using her slide as the last slide, and called me to tell me about it. And I told him, I said, well, I'm glad you got a standing ovation, because Sarah got an award that evening and came off the stage beaming with her new smile. When she went to full smile, I didn't take enough soft tissue away. And I was just mortified that I was just like, I didn't get it. I didn't do it. And, but anyway, so a lot of orthodontists use diode lasers now, and that's because of David Sarver and because of my daughter. But I don't think I made a penny off of that. It would have been good if I had published some papers or something on that, but didn't. It's really difficult in private practice to publish papers. But I had a wonderful career. I enjoyed every second of practice. And I practiced for 32 years, and was very, very fortunate. Over the last little while of my career, I developed an essential tremor, and it came time to, the day came when it was like, it's just time to quit. And you had a great career, you had a great run, and I was just very, very, very fortunate and very appreciative of every opportunity to love the patients, love the opportunity to treat some of the kids that I came to my practice initially, then I was able to treat their children. And And it's just, dentistry is a tremendous profession. And I'm very fortunate to have a chance to be involved in it. I was also very fortunate and thankful that, when the time came, we were able to do that and make that transition. It was not a transition that I really wanted to do, but, I was just trying to listen and say, okay, what's next? And my wife was asking me, I was about a year and a half not really doing anything and playing a lot of golf and this kind of stuff. My wife was like, James, I've never seen you not do anything. I was like, well, I'm just trying to figure out what the Lord wants me to be doing. And I just need to wait. I really enjoyed the time where I wasn't doing anything. And then Steve Bogan is the CEO at BioHorizons Implant Company. He and I have been friends for a long time, as I would do some different things that some of the all-on-4 stuff and all that kind of stuff. And had a cone beam, and I showed him the cone beam and things we were doing with guided surgery early on, before BioHorizons was really doing that. So he, while I was practicing, I helped do some initial thinking about guided surgery for BioHorizons and what the kits might look like and all that kind of stuff. Helped with that. And so Steve and I have had a really great relationship. So about a year and a half after I quit practicing, he ran into him one evening and he was like, come see me. When I went to go see him, I was like, what are we going to do? And he's like, well, how would you like to be a mentor? Okay, you've got my attention. And so what he wanted me to do was affordable dentures and implants is one of BioHorizons' biggest clients, biggest customers. And so Justin Moody was really getting the training with affordable dentures, getting it kicked off the ground. And so I went to one of the courses at Brighter Way and just to observe. And I'm walking around and I'm like, I told Justin, I was like, Justin, I have no idea how much money I spent on implant training in my career. But I've never seen or been involved in something training like this, where, you're sitting there and you're there for a week, you've been involved in some significant training before you get there. But, once the week comes to surgery, you got a week that you're doing implant surgery, and you can place 15, 20 implants in a week if you want to. There's somebody over your shoulder the whole time. And I was like, I've never seen that. Everything I ever did was, okay, we're going to do this for a year. And I was responsible for the patient. So take the patient. Okay, we're going to prepare, plan everything out. Okay, we're going to place the implant that you're going to place. Now we're going to wait a few months, do some more didactic stuff. Okay, now we're going to uncover the implant, place a heating abutment, wait a little while longer, another month or two, and then we're going to restore it. And that would be, I'd do 1 or 2 implants for the year, and that was my training. And I was just like, this is crazy. And Justin has really got a great situation going. And I know there's some other people that have sort of followed his lead and doing some other courses similar to that as well now. And I'm glad that's the case. So implants, in my mind, are a very underutilized part of dentistry. As people are missing teeth and losing teeth or breaking teeth. We've got a ton of people that are dentalists in this country. And from a nutrition perspective and all that kind of stuff, just to have something that's stable in their mouth is life-changing, absolutely life-changing. And so I've been able, and like you said, I've been able to be a part of now most of the courses that come through Implant Pathways at Tempe, and it's been a lot of fun. One of the things that we do sort of on the back end is some of the dentists sometimes, as you know, Philip, they go through the course, and while somebody's right there on top of you, yes, you can do this. But when they get back home, it's sort of hard to get it off the shelf. So I make myself available to do some planning. Download the cone beams to my computer and do a Skype call and walk through the software, because sometimes they don't really learn the software well while they're at the course. And sometimes we'll end up planning 2 or 3 cases up, and I'll show up in their office and, sort of doing over the shoulder with them. And that has been very helpful on several fronts on some of those guys. And so I'm just very thankful to be a part of that.
I like to call that failure to launch there, James. Yeah, that's people get all this training and they get home and they buy buy all the toys the podium speaker tells them to buy, and then they get home and they look around and they just kind of go back to what they were doing. So
right, and their team didn't know about it. They maybe this is a whole different new thing could come in, and when I implemented new things in my practice, I made it work. If I was going to do something, I was like, I'm going to do this or know the reason why. But it's sometimes getting your team to accept what you're trying to try to do, verbal skills. But it's easy to have a failure to launch, especially if you're working on things and say you're not really great at local anesthetics. One of the things that we've sort of seen in the course, suturing techniques and closing things up really, really well, but then also getting it started. Local anesthetics is something that I learned a lot. I'll never forget. I was in dental school. We went through and, we divide up and you could have a partner you do different things with. And so we went through and you get to the day where, okay, we're going to get to the lecture on local anesthetics. And the oral surgery department were the ones that gave the lecture. And so I'd been, from my time at Alabama as an athletic trainer and going through the EMT program, I was used to needles. Needles were something that getting a needle in somebody's vein and all that kind of stuff was something I knew how to do. So I wasn't really all that concerned about needles, and I had never felt a shot. I didn't know that shots could hurt. That was just not a part of my knowledge base, because my dad, I never felt a shot from my dad. He didn't use any topical or any of that kind of stuff. And I never felt a shot. And so we do the lecture, and okay, now we're going to break out and we're going to go give each other shots in the oral surgery clinic. And so my partner was like, I don't know about this needle. And I said, I got the needle. I'm trying to, sit down and I'll give you a shot. So I do exactly what they tell me to do. And he's wiggling around underneath me and all this stuff. I'm like, man, be still. I won't hurt you. And so he gets up and, it was a mandibular block that you had to give. And he said, yeah, I'm numb. All that kind of stuff. And I said, okay, great. I laid down in the chair and I just closed my eyes. I just opened my mouth and said, okay, give me a shot. He hit me and he put me on the roof. I mean, I still remember that. And I was like, oh my gosh. He's like, well, you just did it to me. And so I left school that day and I drove to my dad's office and I walked in and I said, Daddy, I know this is too late to say this, but if you can't teach me something right now that's different from what I just learned today, I quit. I don't have it in me to know I'm going to put somebody on the floor every time I'm fixing to do a procedure for them. I don't want to do that. And so he said, let me see if I know what they told you to do. I said, okay. He said, so they told you had to use the biggest needle you could find, right? Yes. Yeah. You had to use the large 25s and the longs. Have to do that. He said, well, my opinion is, he said, I use the smallest needle I can find, 30 gauge. And he said, I use the shorts all the time. Well, it told me you couldn't do that. And so, he said, so you sit there and you put the needle right up next to the skin. And then you just pull the skin over the needle instead of puncturing the skin. Pull the skin over the needle and also wiggle and jiggle to the tissue a little bit, and sort of put a little pressure with your thumb, And the mind perceives the pressure of your thumb more than the prick of the needle. And I can get in the skin anywhere, and you're not going to know it. And it just taking your time. And another thing that he said, so what do they say about how fast you get? I said, well, they said to give it fast so it wouldn't hurt long. He said, well, I would disagree with that too. And he said, so, maybe take a minute, just take a while. He said, you're putting all this liquid, all this fluid into a muscle or into an area of tissue, and you're spreading that tissue apart. So just do it slow and let the tissue just sort of relax as you do it. And so, that was another piece, is slowing down, taking your time, and what you say, how you say it. And I would, a lot of times I would put my finger, before I would do anything, if I had somebody really nervous, I'd put my finger in the middle of their forehead, and I'd say, okay, just close your eyes and just think about this spot right here. And just relax. Just think about anything else, and just breathe hard, breathe easy, and nice, slow breath, and just relax. And I'd just sort of be talking about something and wiggling along, and all of a sudden I'm out, and the patient's like, when are you going to start? I'm done. And it just, I'm sure you found the same thing. Slow go. All of us have different techniques, but you got to get the needle in the right spot, and you got to also, take it easy.
Yeah, James, it's interesting hearing your story. I've had, very similar entrances into dentistry and entrances into local anesthetic. I went to school for, thought I wanted to do something kind of, maybe athletic trainer or nutritional science, and ended up becoming a dentist like my father. And then
both of us. Yeah,
both of us. And then my experience was very similar to yours. You get into that second year and they teach you how to give anesthetic, and you thought, well, this is a lot different than, Dad ever did it in the office. And so you realize, there must be something, different between the educational teaching and really trying to make a difference in your private practice for your patients' lives, really caring about the individual in the chair. And so, I went to, my dad's practice, I think either that same day or the next day. And I said, okay, you got to show me how to do this right, because either I'm never going to get anybody numb, one, or two, I'm going to hurt them so bad they'll never come back. And neither of those sound good to me. So, he was trained in Pankey and occlusion and taught me all those things in the office too. But, the best thing he did right out of the gate was help train me in anesthetic. Was, he said, get a 30 gauge needle, and, she said, put your thumb back at the posterior ramus, and, he said, stretch it tight and wiggle a lot. And like you said, kind of pull the needle over, slip it in, and then just drip it in, drip by drip by drip by drip. And, he's, and it's, it's very much a craft and a skill, but it's also taking the time to care. And so, I think those, two or three things right there, have been huge for my practice. And it's okay. Patients come in and say, I will never go to anyone else because, one, you give shots better than anybody, or two, you get me number than anybody else. And that right there is just kind of a differentiator. Like you said, with the technology, and being service oriented, also being able to do what we do without hurting people, can be such an asset to people.
Yeah, another little trick that we would do is I would have my assistant turn the suction on right next to the patient's ear right as I was going in. And so I was distractional in two ways. One, they'd hear the suction going, they'd be going like, what's going on with it? And I mean, just anything I could do for distraction. And I love using nitrous and, sedation where appropriate and all that kind of stuff too. But just slowing down and knowing the anatomy, knowing, okay, in the maxilla, let's use a little, in today's world, when I first started, the Septicane wasn't around, but in today's world, with 3 to 4 Septicanes, you can basically almost take the whole maxilla off. and that's all you need. And just knowing where to use what and knowing your anatomy is the name of the game.
Well, let's dive into a little bit of technique sensitivity here, because like you and I have discussed previously in some of these courses, and just talking with people, other dentists, some of the things that I see people struggle with early on in their implantology careers are incision design, is laying flaps, is suturing properly, and then also getting patients profoundly numb. So I know we can't cover all of this, and some of this is kind of a visual thing, but obviously it starts with getting profound anesthesia. So we can't we can't have a good incision design, we can't lay a flap, we can't suture until we get a patient profoundly numb. So I try to spend a good amount of time with my students at the implant pathway teaching or just discussing with other dentists. Let's get them really numb if we're going to deglove the maxilla. What does that mean? And I see a lot of students a lot of dentists that are used to doing maybe operative dentistry, and they're not used to the deep level of local anesthesia needed to do a full surgical procedure. And those are two different
very different things.
Night and day difference of the amount of numbing or the profoundness of the numbing. So, when they get, 2 carps out and just kind of trickle, some here and there, I say, okay, well, that's good for a start. Now, where do we need to go? We need to have, the PSA, we have to reach around the maxilla and get that PSA nailed. We have to come up front and put some in the MSA, and then we have to do the ASA. But then after that, I also say we have to take that needle, and I joke around with them. I say we basically have to put that needle in their eyeball to get up above the canine to get the infraorbital fossa, because when you reflect the whole maxilla, the number one place that people almost always feel it is right up around that canine eminence, because they don't end up getting because we reflect up to the floor of the nose half the time, and so and then once you've tried to reflect, how do you go back in and anesthetize after the fact, right? When the flap's already laid and the tissue's all peeled up and you're staring at bone. So, those are kind of the problems that I see. And then also the palate. Maybe we're not hitting the greater palatine properly or other things. So what do you see as recommendations for people as far as maybe numbing the maxilla for a full surgical procedure?
So I definitely would use Septicane. And so I'm going to put one in the second molar, about a third in the second molar region. And then you're going to have to, and then come in on the mesial of the first molar region, I'm going to put another third. And then I'm going to put up in the infraoral area. Do the same thing on the other side. And then for me, one of the things that I do, Eddie taught me about bending needles. And I know that there's a lot of people out there that are like, no, you can't bend a needle. In my practice, I always had 2 syringes out. And once I used a needle, I never reused it again. And so my assistant would, change the needles out, and I'd be going again. But in the anterior region, I'd bend the needle over and come in at about the area of the cuspid, so that my needle is coming right up I'm going to end up not delivering anesthesia into the nose, because if you go in the nose and it's going back down the back of the throat, it's not going to do anybody any good. And so I would come in that initial time straight there, where I'm just almost coming like parallel to the ground with my needle, and using another third in there on both sides. And then I'm going to come back, and I'm going to, again, like you said, I'm going to go high. Now that I've got everything done, got to go high. And on the palate, one of the things that I would do is, I know a lot of people talk about, they use a mirror handle or something and right by where they're going to inject in the palate, but I never did that. I would take my thumb and I would use a lot of pressure with my thumb on the palate, almost making the palate, like I'd find I can get the palate almost right with my thumb, putting some pressure on it. And then I can put a needle in there and again go slow and give that on the palate that way. And again, you still hadn't hurt anybody. And now I can, once I get one in the palate, I can go to the edge of where I see the blanching, and I can give another one, and I don't have to do anything because they're numb there. And I can just expand that and just keep expanding that a little bit at a time. And now you can do anything you want to. But the maxilla is, you got to, like I said, you got to get high in intestines, and you got to make sure you stay out of pterygoid plexus of veins and posterior. And so you got to stay close to the bone posterior.
Yeah, and I like to use a leg ejector a lot. And like you said, I'll after I do my PSA and give that time, the posterior maxilla numbs up quite nicely. I'll drop a little on top of the ridge and just kind of work my way down the ridge till I get to the greater palatine. Like I said, just kind of blanching ahead of where I'm going. And then on the palate, you can just kind of work your way, blanching a radius and then moving to the edge of that, blanching another radius, moving ahead of that. And that way you're never really poking the person in the palate as much as you might think, because they're not feeling it. I mean, you might be doing more injections, but they're not feeling it at the moment. And so you can really numb that whole soft tissue, and it doesn't take a lot if you get the right pressure and put it in the right spots. You might think, well, you're injecting, maybe 6 places on the whole palate, but it's not. You're not having to use 6 carps up there, and it might be a whole carp on the palate, but you're just working your way around, or half a carp, So it's just a matter of hitting the landmarks appropriately without hurting the patient, and the Septicane obviously gives you the profoundness and the long lasting if you hit the landmarks correctly.
Now, one thing, I had a friend of mine that in an aesthetic case, he used some Septicane in the papilla and sloughed the papilla. And so I've always sort of shied away from that. If I'm doing something where I'm doing, for some reason, I've got to numb the palate. And sometimes I would go into the papilla with lidocaine from the buccal once I got the buccal numb, and just sort of cheat back a little bit until I could get the blanching on the palate from going through the papilla, and then pick back up my Septicane and go to town. But I mean, it's just like I said, it's a lot of it's visual as well. But on the mental foramen, that's another place I would bend the needle so that I knew I was doing it right. I was placing it right on top of it. And then once I placed it, then I'd have a little bolus of, you could feel that with your fingers. So I just sit there and I can massage that stuff into the foramen. And once I got finished doing that, you can really pick your burr up or whatever you want to do right now because it's ready. You're ready to go. You don't really have to wait around for a long time for that. We talk about local anesthesia for a long time.
Absolutely, yeah. My standard operation on the lower, if I'm, degloving a mandible and taking out all the teeth and reducing the ridge and placing implants, that's quite an invasive procedure. You're going to want some profound anesthesia there. I'll do, my inferior alveolar and pick up the lingual, and then I'll drop, maybe a third of the carp on the long buccal, another third of the carp on the mental foramen, and then I'll even put the rest of the third of it down there, kind of, around the anteriors. And so I might drop a whole carp on the IA and the lingual, and then I might drop a second carp on those 3 landmarks on the buccal. So that might be 4 carps on the lower, but then I can do basically anything and everything I need to in that person's lower jaw. And I find if they're not numb on the lingual by chance, or they're partially numb, then you can put just a little bit in the floor of the mouth and that under that paper thin tissue and drop it right there, and that just soaks right up in case there's a mylohyoid or accessory nerve, or if just by chance they're just not profoundly numb there. So I find that with 4 or 5 max, you can tackle the whole lower.
Absolutely, and one thing that I would do, for me, I I'd wait on that long buckle until the patient said, yeah, I'm numb all the way to the middle. Once they told me I'm profoundly numb to the middle, okay, now I'll do my long buckle. Because if I do my long buckle, as soon as I finish my mandibular block, I got no clue whether or not I actually got them.
Sure. Yeah, you won't know if the teeth are numb or if it's just the infiltration. So that's good advice. Do those and give it 5 or 10 minutes and make sure they're numb, and then after that, touch up the soft tissue, and then you're ready to go. Yeah,
ready to go.
Great point there.
So when you're going to lay a flap, so are you going to take and make several incisions, or are you going to try to make one incision for the whole, going all the way around? Sometimes I see some of the students, and there'll be several incisions, and then all of a sudden, when you're trying to sew something back up, you've got these little jagged areas all the way around. And I'm like,
yeah, and that's another thing we talked about. That kind of their toughest moment is, I like to take out all the teeth first, and then I'll pick up my blade and I'll do a kind of a distal, kind of a hockey stick release, past posterior the second molars and the mucogingival junction, and up to the posterior ramus kind of tailing off, and then I'll go mid-crust all the way around and then release it on the other side. And I've just got one cut, with my releases, and I'll just flap the whole thing there. And what happens is, unfortunately, is if you're not good at your releasing flaps or with your incisions, if you get a bunch of tears or a bunch of cuts, what happens is at the end of the procedure, it gets significantly harder to close it, even if you're not grafting. And if you're grafting, it gets significantly harder.
Right.
And the problem with that is you're not getting a clean suture. You're not getting the wound closed up the way it should be. You'll lose graft material. You have possible infections. You've got irregularities of where the keratinized tissue might be, or you might destroy the keratinized tissue to begin with. So that's the biggest issue there is having one good suture, or one good incision, and then having a good ability to suture that up properly. I think those become the most difficult things to do after you get patients numb, is opening and closing your operating field.
And then judging how much bone to take away. When you got enough. In 1984, the word was don't take any bone away. We're just trying to save everything because but then also in 1984, nobody knew anything about grafting, and only an old surgeon could maybe graft something, maybe, and all that kind of stuff. And but once I learned how to think about just socket grafting, that one thing changed my life. Was just, okay, how do I prepare a site to be there, when I'm ready to go again? And I don't know about you, but I took maybe 3 grafting courses before I'd come back from the grafting course, and I was a failure to launch. I'd say, okay, we can take the tooth out, and it'll be this. And take the tooth out and graft it, it'll be this. Well, everybody said, well, just take the tooth out. I don't want to graft. And I was like, well, nobody will buy this. Nobody will take it. And then one morning, I was sitting there and I was like, wait a minute. Just out of the clear blue, it was like, James, why are you not grafting everything? It's in the patient's best interest to graft it. And not until I made that transition in my mind did I start grafting.
More of a mind shift for you than it was the patient.
Yes. It was my attitude about the whole thing. And that, look, you need this graft. And so there might be sometimes I wouldn't graft it after that. But by and large, I'd say 95% of the time, if I took a tooth out, I'm going to prepare that site. If I'm not placing an implant in, I'm going to prepare it for an implant at some point in time in the future. You've been doing this long enough to see this. You have somebody come in and they have a condition where they've got 3 kids in college or they've got whatever going on, and they really don't have cash flow to do something significant right now. And so that's fine. They get something that's not as good as you can do, but it's something that's adequate. And then all of a sudden they come back a year or 2 or 5 years later and say, hey, look, you talked to me about doing whatever. Can you still do that? And if I hadn't prepared that site properly, sometimes the answer was, well, no. Not really well. Or it's going to be a whole lot more involved. And, and so my attitude, I had to change my attitude. And it was just, and I don't know whether that was from, the whole oral surgeon thing and all that kind of stuff. And I needed oral surgeon. The team that I had here in Birmingham, Kevin Sims was my main team we did around implant. Was periodontist and myself. And we did a lot of significant cases. Once I got my cone beam, I could figure out, okay, I'm going to do this one. Or else I'd walk in his office with a CD and I'd say, okay, Kevin, how are we going to do this? But I knew what was in my playground, and I knew what was not in my playground, and I could figure that out. And the cone beam technology and having the right stuff to be able to make a decision. I don't know how you would practice dentistry today without a cone beam. That'd be I could probably practice dentistry without a laser. I wouldn't want to, but a cone beam and things like that. And for me, the microscope making me have the right posture. That's another thing in these courses. I had horrible posture for years and years and years, and so my shoulders droop a little more than I want to, and I'm working on that with physical therapy and all that kind of stuff to sort of try to straighten some of that stuff back up now. But I'll take a picture of some of the students that are going through the courses with us, some of the younger doctors, and I'll show them a picture of them in the contorted position that they're in while they're doing this procedure, and I'll look at them and say, now, if you keep doing it in your position like that, you're going to end up looking like me.
Yeah, that'll scare them. Yeah, I better really give it to them there. Yeah.
But, so I'll try to just sort of, and the more that the thing that the microscope taught me was posture. And the better posture that I had, the more precise I could be while I was working on somebody.
Well, and it also shows you the biology in a greater detail, and your limitations or your masterpieces would show up bigger and better. And my father had 2 microscopes when I entered the practice, and that's kind of how I learned endodontics was on the microscope. And then I realized there's so much more than just your ICs, even with loops on. But it's that continual refining. Okay, where are we at, and how can we get better? Whether it's our posture, whether it's our procedure, whether it's our margins, whether it's this or that. The things I tell students or dentists or whoever is it's learn to get patients really numb and extract every tooth in the mouth, because until you can get them really numb or you can extract every tooth in the mouth, in my opinion, those are the fundamentals of oral surgery. I mean, let's not talk about all on 6 until you can get every patient numb and pull every tooth in your office. And then, like you said, you got to have a CBCT in your office. I wouldn't go back without them. And then, when you want to take your restorative to the next level, if you really want to be the cosmetic guru, I mean, don't even have that discussion until you have a microscope in your office and you've mastered lasering. But it's knowing that there's a bigger game to be played out there. It's understanding. It takes the speaking and leadership and the soft skills to mature just as much as your clinical skills. And so you have to kind of work on the 2 complementary and ratchet yourself up every so often.
one of the things that as we've been doing these courses, I've been so thankful. I worked in oral surgery every summer while I was in dental school. And one day I was in there struggling with his tooth, and I had to force it, but I was struggling. And one of the oral surgeons walked by, and he took the forceps out of my hand, looked at me, and put an elevator around my hand, and said, "Okay, until further notice, this is all you can use to take a tooth out."
And to be honest with you, that's all I use in my office is elevators.
I was like,
that's all I use. Yeah, exactly. It's kind of somebody turned, kind of pulled the rug out from under you, but it eventually understood what he meant. And
yes,
yeah, that's where the work's done, not with the forceps.
You can also blow a buccal plate with that real easily, but knowing the fundamentals of surgery and how, and looking at an instrument and understanding, okay, this instrument was designed to be used in this specific fashion. And if I don't know what that is, I don't need to use that instrument. And we have some really bright people who've got to, figure some of that stuff out and use it right. And it just makes all of the difference in the world.
Absolutely. It's figuring out what the right instrument is half the battle, and then the other half's figuring out how to use it right. Yeah, I mean, most my extractions are if it's a really hard tooth, I'll just section it and then elevate it. But if not, I'll just elevate it. And part of that's because it works, but the other part is because I'm preserving the buccal plate. Because in 100% of my teeth that I take out, if it's single teeth or I'm coming back there, I'm socket grafting or grafting to some preservation, or if it's one of these full arch extraction cases, that I'm still keeping the buccal plate and then flapping and then deciding where to reduce for my prosthetic space or my surgical space or whatever. But until further notice, I'm just not going in there and breaking everything and then trying to put it back later. It's okay. Let's use things properly. Let's pre-plan things with CBCT, and then let's execute for prosthetics and occlusion and function and aesthetics. But every little thing, every little trick, and every little thing helps. So it's just kind of you got to know who to put yourself around. What kind of people what will want to show you and teach you. That was half of my battle early on was who's going to show me this stuff. Because the oral surgeons, periodontists didn't want to. But who's going to show me these things? And I think that's where, I'm really proud about the implant pathway now that, Justin's got his own clinic and he's been running this thing for, I don't know, maybe 3 years now. And, couldn't think of a better guy to run an educational facility. Not as only, one of the most giving people ever, but, he's got the diplomat status and the credentials to do so. But then he's surrounded himself with other great people who have experience. He's linked up with, BioHorizons, a great company, and just the mentoring side, like what you're doing now. Not as I know it's rewarding for you, but it's such a needed thing in implant dentistry. The leadership and mentoring for implant dentistry, has never been more needed than it is now, in my opinion.
One of the things that I learned from Coach Bryant. He would say, okay, if you want to be the best, and that's something you need to figure out. You need to decide if you want to be the best, you have to surround yourself with people as good or better than you. The people that you surround yourself with will determine whether or not you're going to be the best at it or not. And that is completely true. And, whether it's my team, whether it's, who am I going to, go learn from? And, where am I going to figure some of these things out about occlusion and bite? And, it's just, if you want to be the best, you got to surround yourself with the best. And that works. It works. I don't care what it is. I don't care if it's tiddlywinks, or I don't care if it's, football or dentistry or whatever. That's the name of the game. And but in dentistry, you have to have great people around you, whether that's a laboratory that you can communicate with. I learned so much from my laboratory technician. I learned as much dentistry from him as I did anything else. And I was always, and I told him at the beginning, I said, look, if you see something that I've given you that you don't like, you have permission to correct me on it.
Yeah. No, yeah.
One did,
But you and me might be the 5% of dentists that'll do that, because I call them and say, look, you guys see everybody's work. I just see mine, tell me if it's no good, or tell me what I need to do. Or, your results can only be so good as what I'm giving you. So I need coaching,
right.
And I think if you're not open to that, then, check your ego at the door. And with, learning implants, you're only going to be so good as, are you going back and cone beaming your cases afterwards? Are you taking photos and evaluating your work? Are you going back and judging,
right.
Where can I do better next time? How can I improve this outcome for the patient better? And like you're saying, surround yourself with people who are maybe a couple notches higher than you, not for any other reason that maybe you can ratchet your way up to that level.
Right.
And people that are willing to help you do that.
Because if they're not willing to help you do that, my experience is they may not be as good as you think they are, or something else is wrong. But the people that are willing to give and sit down and talk with you, it's just that's been one of the things that's been really great. For a guy like me, where I was like, okay, well, my career is over in dentistry. So now I have the opportunity to, well, maybe it's not over, and maybe I have a chance to, maybe I'll be able to help somebody that I'll never put my hands on, where before I had to put my hands on all of them, and so it's a different role, but I'm very thankful for the opportunity to do it, and it's been fun. As long as I can do it, I'll do it some more, and it also sort of keeps me, I'm in the front of, again, dentistry is something that I always try to figure out, okay, where do I think dentistry is going? And then I would try to position myself there as soon as I could, and try to learn about it. And that's part of the reason why I had all these extra little things around me. But anytime I brought something to practice, I would definitely make sure I did it. But trying to implant dentistry is going to be huge, but also, our profession is just under such, there's a lot of pressure on our profession today from a whole lot of different things. But, I'm helping a lot of corporate entities in some of these things, but at the same time, I still personally believe with every ounce of my physical being that there's a segment of our society that wants service and is willing to pay for it and wants the best that you can do. They want to smile and look natural. They don't want, if somebody knew something different happened to my patient, but they couldn't tell exactly what it was, bingo, that was a home run for me. That was where I was trying to go. Is go there.
Yeah, there's always going to be room in the market for treating people right and doing a good job for them. And I think people want that, and sometimes more than ever. I mean, because it only takes getting burned a couple times before you realize, hey, maybe I need to go somewhere where I'm not just a number, or maybe I need to use this company where I don't feel like I'm just a paycheck to this rep, or so on and so forth. And people that want that are going to want that, and they're okay paying what it's worth. And so whatever that is, whether it's cars or whether it's jewelry or gadgets that people buy, or dentistry, I think if people want it and they value it and they think that you provide that service and caring, and of course you got to be able to deliver the goods, but I think that's where your opportunity lies, to say, okay, differentiate yourself and step up to the plate and say, let's make this thing happen. And I'm just glad that you've been a part of the journey there, and I've had the pleasure of meeting you, and and looking forward to some more of our adventures. I know we've got some fun things coming up this fall with implants and football and everything else. So I'm just really, like yourself, kind of trying to stay, with where the new frontier is heading, knowing that things are always moving. But surround yourself with good people. Invest in good technology, treat people right, and do your best. And I think if you're doing those things, hopefully things work out for the way they're supposed to.
That's been my experience. So, Philip, I've really enjoyed it. The opportunity to visit on this podcast, and hopefully we can figure out some other things and talk some more in the future on some of these. There's a lot of things to talk about, and I just enjoy the opportunity, and just want to thank you for giving me the opportunity to do this tonight.
Absolutely. We'll definitely have you back. We'll just pick another topic and dive in deeper. So glad to have you on, and look forward to seeing you again sometime, buddy. So have a great evening, and we'll talk to you soon.
Thank you.